Hello, everyone. We're just going to give it a few seconds. Let everybody get on the webinar. Minute to get started. Okay, good evening, everybody. We're going to go ahead and get started. Welcome to this evening's Summer of Social Impact events, Health and Wealth, COVID-19, Inequality, and the Need for Reform. Now in its fourth year, the Summer of Social Impact series at the Harris School of Public Policy explores innovative approaches that are making an impact on major policy challenges facing our city and our world, such as the need to reduce poverty and inequality, strengthen our democracy, and create a more sustainable environment. Today, we're thrilled to have nearly 500 attendees with us, including alumni and friends, current students, and Civic Leadership Academy fellows. We're especially excited to have so many of our incoming students participating tonight as the newest members of the Harris community. My name is Ben Mothker. I'm a graduate of the lab school, and I'm a current student at Harris. I also have a depth of experience in the sector as a physician, a healthcare administrator, and more recently as the co-founder and principal of Revenue Health, a boutique healthcare consultancy that supports physicians and health systems in their return to financial health. These experiences have really instilled in me a deep appreciation for the complexity and challenging nature of healthcare policy. And as the recent pandemic has revealed all too clearly, we cannot have a conversation about effective data-driven healthcare policy without also examining the pervasive inequality that exists within our system. Which brings me to tonight's program and to the phenomenal and renowned scholars who will be leading our discussion on this timely and critical topic. This evening, I'm honored to be introducing our first panelist, Dr. Damon Jones, an Associate Professor at the University of Chicago, Harris School of Public Policy. Excuse me. Professor Jones conducts research at the intersection of three fields within economics: public finance, household finance, and behavioral economics. His current research topics include tax policy, Social Security, retirement and retirement savings, and the interaction between employer-provided benefits and the labor market outcomes. Professor Jones holds a BA in public policy with a minor in African and African American studies from Stanford University. He's received his PhD in economics from the University of California, Berkeley. And today we welcome Professor Jones. Welcome. Our second panelist today is Dr. David Meltzer. Dr. Meltzer is Chief of the Section of Hospital Medicine, Director of the Center for Health and the Social Sciences, and Chair of the Committee on Clinical and Translational Science at the University of Chicago, where he's also a professor at the Department of Medicine. Dr. Meltzer is also affiliated faculty at the University of Chicago Harris School of Public Policy and the Department of Economics. His research explores problems in health economics and public policy with a focus on theoretical foundations of medical cost effectiveness, analysis, and the cost and quality of hospital care. Dr. Meltzer received his MD and PhD in economics from the University of Chicago and completed his residency in internal medicine at Brigham and Women's Children's Hospital in Boston. Welcome, Dr. Meltzer.
Thank you. And
finally this evening, I'm thrilled to introduce Dr. Katherine Baicker, who will be moderating this discussion. Dr. Baicker serves as the Dean and Emmett Dedman Professor at the University of Chicago Harris School of Public Policy, having been appointed to the role in 2017. Dean Baicker's research focuses on the effectiveness of public and private health insurance, including the effect of reforms on the distribution and quality of care. Her large-scale research projects include the Oregon Health Insurance Experiment, a randomized evaluation of the effects of Medicare coverage. And before coming to the University of Chicago, Dean Baicker was the C. Boyden Gray Professor of Health Economics in the Department of Health Policy and Management at the Harvard T.H. Chan School of Public Health. And Dean Baicker earned her BA in economics from Yale and her PhD in economics from Harvard. This evening, please join me in welcoming all of our panelists. Dean Baicker, take it away.
Great, thank you so much for that introduction. And I wish that I could see all of the people who are here, but I'm delighted to have you with us. And these are clearly the crucial policy questions of the day. And we at the Harris School have been very busy diving into how public policy can help address myriad challenges, but none more important than the twin health and economic crises that so many different populations are facing and that are hitting different populations in such different ways. And I'm really glad that we have David Meltzer and Damon Jones to talk with us about that. So I want to start with a basic question for both of you. We're experiencing an unprecedented health crisis that's compounded by the economic crisis that comes with it. And as an economist, I've been trying to think about how to weigh those things against each other in guiding optimal policy. But in some ways, you really can't choose all one or all the other. All of our emphasis on just saving lives or all of our emphasis on reopening the economy, especially when there are such disparate effects of these two crises on different populations. So what is your sense of the direction policy should be going in terms of balancing these competing needs, and how are the effects being felt differently across different communities? And maybe I'll start with David, because he's unmuted, and because, as my mother would say, he's a real doctor. And then we'll the economist weigh in. David.
Sure. So I'll give you a real doctor answer to that rather than an economist answer to that, although it's a little bit of both, which is so I'll give you an economist answer to the doctor answer, which is you start by getting on the budget constraint. In other words, look for those things that you can do that make it possible for you to mitigate some of these trade-offs. And one of the things that's been striking for me as a clinician, I'm still a primary care doctor. Actually, I have my own patients I care for. I run our hospital medicine program, and then I run this program called the Comprehensive Care Community and Culture Program, which provides care for very low-income, vulnerable older adults, largely on the south side of Chicago. And the striking thing in caring for my own patients and for helping this program reach out and try to address some of these issues, and I'll talk a little more later about some of how we've done that, is that there are incredible opportunities with thoughtful action at the level of individuals and through public policies to mitigate some of these trade-offs. So, one of the obvious examples of this is, you have a relative who you live with who is working out in the community, needs to work in order to support their livelihood. You currently live together. You're a vulnerable older person whose probability of death if you're exposed to COVID is incredibly high. What do you do? And the answers are very creative sometimes, which is you have another relative who lives nearby and you work out a way that, you live with that other relative for a while, or the relative who needs to work lives with someone else, or you take precautions in how you interact within the home. So there is no question these trade-offs are real and that they exist. But the reality is there's so many opportunities if you really think hard about how to try to mitigate them to make it less. And so that's kind of the doctor answer to where to get started.
Damon, what about the economic conditions and the hardships that this is exerting differentially across communities?
Well, I think that solutions to economic and health problems that we're facing, on one hand, there's a trade-off between reopening the economy and maybe trying to limit infections. But I think that there's a way in which we need to see them as one solution making the other one easier. So I think that trying at the beginning of the pandemic, we seem to be really caught off guard and really limited in how we could address this. But we've seen very different trajectories in infections and deaths across different countries now that have comparable levels of resources and things like that. So it no longer seems like what is happening in the US is unavoidable. And so I think that that's one, maybe, I wouldn't say embarrassing, but we could be doing better, but it also gives us maybe hope that there's better things that we can do. And I think that one, there's an economic angle to the health crisis in that there are a lot of things that we should be trying to increase the supply of as much as possible. We have limited equipment that people use for safety, tests that people can access in order to be as safe as possible if they have to work. We should be lowering the cost of those things as much as possible in order to aid in keeping infections under control. In the meantime, I think that we, also should, from an economic standpoint, we can give a lot of people relief, economic relief, and that can help with trying to solve the issues of the health crisis and infections, because for those people who are not essential to working, to the extent possible that we can give them support so that they don't have to go into work, or they can, you know, remain out of the labor market until we get things under control. That type of economic policy both can provide people relief and make it easier for doctors like David to, you know, to deliver care to the people who are getting sick. In terms of differential impacts, I think there's a number of ways you can think about who is going to be differentially impacted by the types of things that are happening during the pandemic, which is combined with a recession. And so I think that there's not one bottom line description, but you know, you want to think about different groups of people who are particularly vulnerable, those people who work in what we call essential jobs, people who don't have a lot of savings set aside for these types of emergencies, people who were not plugged into public benefit programs that we're now using to distribute relief. So the unemployment insurance program, the IRS, loans through banks, people who are less connected to those portals through which you can get relief are going to be more vulnerable as well. And I'm sure before the discussion's over, we'll dig deeper into how those interact across different racial and ethnic groups as well.
It's a really interesting point about the interaction of these crises and the policies to address them that I want to drill into. Let's start with your perception, Damon, of how well the federal programs to date have worked at providing income support to families, and what you think the right steps going forward are, particularly given that some of those benefits are set to expire this month. Have they worked, and how should they be continued, or should they be changed?
I think that my impression from looking at what people have been able to gather through data and things like that is that the main way that we've tried to give people relief, a lot of people have benefited from them. We've extended unemployment insurance much more than we ever had in the past, making more people eligible and increasing the amount you get. And that has shown up in the data as buttressing people's income while they've lost their jobs or their household has lost income. Now, the timing of when people receive this type of relief, it varies a lot. Some people face delays in when they would start to get their unemployment benefits or a check from the IRS. Some people still haven't received it. And so there are people who had delayed payments, and on paper, once we ask if you've ever received this type of relief, it looks like many people have received it, but there's still a gap between when you are in need and when it's delivered, where people, especially people who don't have other things to draw on like savings, are maybe going to be in a particularly tight bind. So, you know, measures of food insecurity have gone up, and for example, and then there are certain groups that are completely excluded from these types of benefits, like families with an undocumented adult in the household are not eligible for these economic impact payments from the IRS, for example. You know, there are people who are homeless who are particularly undercovered by some of these programs. So I think that the relief that has been put in place benefited a lot of people, and there are particular groups that fell through fell through the cracks that we know about that we should address, both by continuing with the types of relief that we've been doing and increasing our ability to get relief to some of those people who are left out. And so things that we didn't do the first time around that we want to make sure to focus on is giving more money to state and local governments, because they can maybe have a better chance of getting at some of those populations, like homeless populations, for example, who are not in the IRS system and easily delivered a direct deposit payment. We can think about expanding eligibility to undocumented families or individuals. I think that the stuff that we are doing that is set to expire, we definitely need to renew. So the unemployment insurance expansions are set to expire at the end of July. And I think that, you know, it'd be a huge mistake to discontinue those. We know from research from our colleague Peter Ganong and his co-authors that when unemployment insurance benefits expire, there's a huge drop in people's spending on goods that they need to survive when those things expire. And so we can expect a huge adverse impact on people if we don't continue those things while we are currently still in the heart of a recession.
So there's some really interesting parallels between groups that are left out and groups that are more connected to resources on the income support side and on the healthcare side. David, on the healthcare side, how are you seeing patient populations have access to care? How is care differing between advantaged or disadvantaged populations? How is the disease burden distributed? What are you seeing in your patient pool and more broadly?
Yeah, I have more limited knowledge of what the most affluent are receiving, but I have some sense of it. I think the differences there may be smaller than they are with respect to economic access. I think everyone is struggling to get into clinic. In fact, doctors aren't seeing patients in clinic very much. Much of it has been virtualized. Non-essential surgery was essentially stopped in Chicago for many months. So everyone, kind of regardless of income, is experiencing some measure of decrease in access. Not all of that is bad, I will say. I just had a wonderful experience today where I, for the first time in 4 months, was able to actually see 2 of my longest standing patients. I used Zoom to connect through. This is one of the fascinating ways in which money affects access, right? So my patients may have smartphones, but they probably don't have wireless, and they probably don't know how to use them. So I can't really FaceTime with them or Zoom with them. I'm lucky if I can talk to them. But today I just got lucky, and a visiting nurse saw 2 of my patients back to back, and I was able through her cell phone to do video talks with them. And it was amazing. I was able to look at things they wanted to show me and interact. And these are people who by any standard have very low income. Now, my parents who are here in Chicago are far more affluent. They probably could have finagled those sort of things themselves if they thought to. But this really was a matter of an interested clinician, patients, and a visiting nurse. And so, there's a lot that can happen there. Now, that much said, there's no question that the healthcare system has struggled with respect to access, and particularly some of the most vulnerable hospitals in Chicago have struggled. So we were working actually with a group of Harris students on a program to extend one of my, this comprehensive care program to one of our community hospitals. And I won't name it just because it's easier to speak candidly about the challenge, but this is an extremely challenged institution. And they really had to just shut down absolutely everything else to deal with COVID. And I think there's very little question that there were things that it took them, and actually it's not just one hospital, it's several that I can think of, that it took them longer to figure out how to do than it took us to figure out how to do. And so there were lags there, but when it comes to COVID, those things matter. They're not determinative as often as you might think, because honestly, there's only so much you can do in many instances. So there's no question there are access issues. I would say there are less. One thing I will also add, when Damona's talking about sort of the resources people have at home, one thing that's really interesting is home health services have become key. And I don't have data on this except my practical experience. And my sense is that the demand for home healthcare nurses and home health aides and the kinds of people who can go in the home has just shot through the roof and is well beyond the capacity of the agencies right now to actually satisfy. So it'll be interesting, with licensing and other sorts of things, whether given rising unemployment rates, there's some reallocation of effort towards that sector in time. But there's a clear supply problem now. And it would not at all surprise me that in the context of those sorts of issues, that people who are in less affluent neighborhoods or whose insurance is not as generous are struggling to get access. The one last thing I'll say is, I think everyone's well aware of all the problems of nursing homes. And there is absolutely, without question, an incredible socioeconomic gradient with respect to mortality in nursing homes. I mean, we have seen that very clearly, and there are probably many reasons behind it. But there's one nursing home in Chicago that's on the Gold Coast where, as I understand it, there hasn't been a single case, and there hasn't been, of course, any mortality associated with it. And then there are other nursing homes on the South Side, on the West Side, where the person who hasn't gotten it is the exception.
So one theme that's actually come out from both the health side and the economic side is resilience of the system and of the individual to weather these kinds of shocks. Is the health system ready to handle this influx? How does that vary in different nursing homes in different communities, in differently resourced hospitals, but also on the individual family side? This is a huge shock if people are laid off, if access to unemployment insurance is limited, especially if wealth and savings are really limited. And Damon, you've done some really important work on not only the income gradient that we see in the country, but also the wealth gap, the savings gap. And how do you see that playing out in times of crisis like this?
I did some research along with a team of researchers. There were 5 other co-authors. 2 were at the University of Chicago. 1 is at the Harris School, Peter Ganong. And we looked at using administrative data from Chase Bank that could follow people's month-to-month income and spending. We just looked at how sensitive people are to changes in their pay. So you could think about cuts to your pay even though you continue to work, or you could think about job loss when you become unemployed. And what we found is that people spend less on needed goods, which we call non-durable goods. So these are things you want to buy and use in a very short period of time: food, groceries, and things like that. When people have less income coming in, as you would expect, they are able to spend less on those goods than they had in the past. But what we found was that that experience differs across different types of households. The households who were most vulnerable to these changes in their income are those with low levels of liquid assets. So that would be cash or assets that you can easily convert into cash. And those households had the largest drop in spending on needed goods after they lost income or lost a job. And in that study, we also looked at this comparison across different racial groups. So we looked at white households, Black households, and Latinx households. And so in this study, what we also saw was that because there are pre-existing large gaps in wealth across racial groups, then these patterns followed along racial lines. And so Black and Hispanic households were more sensitive to losing income or losing a job in terms of the spending they could continue to do relative to white households. And a large part of that story was because they had lower levels of liquid assets. And
that also, of course, plays out in the relationship between employment and insurance, the types of jobs that people have and resilience to changes in economic circumstances. Most privately insured Americans get their insurance through their jobs. There's small groups who get health insurance through the ACA or Obamacare marketplaces. They're publicly insured populations, but millions of people get their insurance through their jobs. And when they lose their jobs, they risk losing their insurance if they were in that lucky group where they got insurance through their jobs. How are you seeing this play out in labor markets and in health insurance markets, this tie? And do you think that there's an advantage to having that kind of system? Are there other systems that you'd rather see in place to promote continuity of insurance and care?
Yeah, so I've looked at some studies that have tried to quantify this, and as recently as a month ago, they estimated that about 78 million people lived in a household where a job was lost in the United States. And of those groups, some people could switch on to the insurance of someone else in the household, but about 27 million were likely to, because of that job separation, lose their employer-provided health insurance. And then of that group, about some were eligible for Medicaid. They could switch to Medicaid based on their income, but at least 20% were just ineligible for any other type of publicly subsidized insurance that they could switch to. And so because we have, for that group, in the healthcare market or in the healthcare system, we have about a half of everyone who's covered by health insurance, or about a half of people are covered by employer-provided private insurance. When something happens like a mass loss of jobs like we've had during this pandemic, the fact that we have insurance linked to where you work for these people, I think is exacerbating some of these problems in terms of accessing healthcare. And I think that decoupling that through some sort of universal alternative would have allowed people to have more continuity with their healthcare while many people are now facing job loss.
Yeah, let me also add from the hospital side, there have been many hospital closures already, and I've seen a range, it goes into the hundreds projected of hospital closures because of COVID. The big private hospitals are not doing well, but at least they have the CARES Act to help them. One of the, I think, less well understood aspects of that is they provide support to try to make whole or closer to whole the very large hospitals, but small hospitals, I think with less than 50 or 100 cases of COVID actually don't get anything. And so, all hospitals, to some extent lost a lot of volume when this happened. And so that's going to be one of the big things that's going to affect access. Some will be safety net hospitals in urban environments, but many will be rural hospitals. And one can have mixed feelings about some rural hospitals closing, but there's no question that some critical access hospitals are likely to be impacted by this as well.
So following up on the thoughts about continuity of care as well as insurance, David, tell us a bit more about your work with the comprehensive care program and what we're learning about the nature of the doctor-patient relationship in helping particularly high health need patients work through the system.
Yeah, and maybe particularly in the context of this crisis. So it's interesting. So the background for this is I have for many years been interested in studying the value of medical specialization, and have been focused on trying to understand whether having doctors who specialize in inpatient care actually improves outcomes. And we found mixed evidence as to whether that sort of a form of expertise is valuable. One of the clear downsides is the separation of inpatient and outpatient care that comes with that. The consequence being that if you're sick and go into the hospital, you're cared for by someone who doesn't know you very well and may not understand your social context or disease well. And so we developed this program a number of years ago that we called the comprehensive care physician model or comprehensive care program. And we built it out here at the university. And in that program, you have the same doctor who can care for you both in and out of the hospital. And we've studied that through a large randomized trial with 2,000 patients, 1,000 randomized to the program and 1,000 to a control group where they get different doctors in and out of the hospital. And we found very, very large reductions in hospitalization rates, and outcomes that are at least as good as better, savings of several $1,000s per patient per year. And we're busy really spreading this all around Chicago and all around the US and even internationally. One of the big observations from that work was that there was a significant group of patients, particularly ones who were socially vulnerable, who even when they had the opportunity to get care in the program never really took advantage of it. And we hypothesized that if we could build social programming to try to better engage those patients, that they would take advantage of the program and do better. So we got funding from the Robert Wood Johnson Foundation to create this program we call the Comprehensive Care Community and Culture Program that begins with this comprehensive care model of the same doctor in and out of the hospital, and then adds to it, first of all, systematic screening for unmet social needs in 17 different dimensions, a community health worker who can help respond to those identified needs and catalyze help from social work and social service agencies. And actually with that, a sort of social service learning collaborative that tries to help those organizations collaborate. And then finally, a community-based arts and culture program that really tries to engage the patients. And in that program, we're finding even bigger savings, reductions in hospitalizations than we found in the original CCP program. So when COVID hit, we had 2,000 patients active in this study. More than 1,000 of them in the intervention group and here on the South Side. So, you know, the first thing we knew we needed to help patients do is understand what the threat was that they faced. So we quickly wrote up a bunch of scripts of sort of simplified versions of, you know, what you would want people to know about how to minimize your risk and how to stay safe. And we actually run an AmeriCorps program. So we have a bunch of recently graduated college grads and people from the community who work with us. And we called over 1,000 people in 10 days and got them on the phone, started talking to them about this. We ended up doing town halls on this. I ran them personally and some of my colleagues did them as well. And we'd have anywhere from 5 to 20 people from the community on the call talking to them about what is this virus, you know, what do we do about it? How do we stay safe? How do you get the help you need? What are the challenges that you're facing? And it was amazing to listen to people talk about the challenges they were facing, the creativity with which they were dealing with them in some instances, in some cases, just the real struggles they were having. So that's what we've been engaged in doing. It's been really interesting. It's set up in such a way that we will eventually be able to evaluate whether it actually helped. But it's certainly been incredibly personally satisfying. You sort of, you know, finish these calls and you really feel like, you know, you've helped a couple of people. And that's a good feeling.
Well, you're highlighting the importance of a robust set of social safety net programs that right now is challenging because of how patchwork it is, in a similar way to the patchwork nature of our healthcare system. Damon, you've done some work on a universal basic income program and thinking about the earned income tax credit and other mechanisms of providing support, particularly income support to families in need. Tell us about universal basic income and what you think the potential of that is to help fill some of the gaps.
Well, I think that with income support programs, more recently, universal basic income has become a very hot topic. And usually when I'm asked about it, I give the very academic response of trying to make it more complicated than it's being, you know, packaged as. So when people talk about universal basic income, there's a couple of different features of policy that they're putting together, and some that may be less thought about than maybe they should be. So I think about these policies having a couple of pieces. One is there's the basic income part of it, which is that there's an income floor below which your income can go that kind of acts as a safety net. So that means that you're eligible for this type of cash relief from the federal government, let's say, even if you're not working or if you have no other income, which is a different model than the earned income tax credit, which is a big cash transfer that we have in the tax system that you have to work in order to be eligible. So one thing is thinking about how much income support goes to people even if they don't have any earned income. And I think that's one key component. The other thing is this universal idea where people say that, well, it should be very, the administrative burden should be very low in terms of who qualifies, because the more that we think we create barriers to eligibility, the less that the people who really need it will get it. The trade-off there is that when the more people that are eligible, the more that you spend on a program like universal basic income. Here, I think that the framing has maybe a little misleading. And the reason why is that if the policy is designed so that it's paid for through somebody's tax payments to the IRS, then it can't be truly universal because somebody is paying more into the system than they're getting out from this type of program. So I think that that part of this policy discussion, I think, needs to allow for a range of outcomes or designs of the system. I think the key thing is that you want to have an income floor below which people's earnings won't go because the government will kick in. In terms of who's going to pay into the system versus who's getting out, that's a very flexible thing that we can decide. It can be that there's a tax increase only concentrated among the ultra rich people in society, and then that pays for some payment that goes to almost everyone else. Or it can be that, you know, this tax is generally paid for by the rich and it's a transfer to people with middle to lower incomes. But I think that we don't talk about the financing as much when we talk about this policy. And in reality, if it's going to be financed through taxes, somebody is paying in more than they're getting out. So I don't know if it can be truly universal unless you just run up the deficit and, you know, but in general, I think that what people are talking about is going to be financed from some source. So, but I do think that there is a shift in discussion that's very important to take note of, and that is in the 90s, we shifted from traditional welfare to programs that pay you if you work, and that has strong implications about who may be deserving of this support. And I think that maybe people are willing to reevaluate whether to evaluate that design, both from theoretical and economic, like there are technical questions in the field of economics about whether that is the best way to go about it, and also from a more, I would say, just ethical or moral standpoint about what signal we're sending when we say you have to work in order to be deserving of this support. And so I think that's one thing to think about. And we tried to do some research to see how this affects other things that people do. One thing that people criticize basic income on is to say that it will lead many people to stop working or to work a lot less because now they have this unearned source of income. And, you know, that's a reasonable maybe conjecture, but we wanted to see what happens in practice when this type of policy is rolled out. There is no like policy on the scale of a basic income that is, I think, rolled out en masse, but we looked at Alaska where they do give out an annual cash payment to people once a year to every resident in Alaska. And so when we looked there in Alaska, we found that compared to states that seem to be very similar to Alaska before they started doing this, Alaska doesn't seem to have a very much lower employment rate than those comparable states. So we didn't find as much strong evidence that people are working less because they're getting this annual cash payment from the government that's universal. And one hypothesis that we have is that when you give people this cash, they also tend to spend it. And so that could feed back into the economy, stimulate the economy, and cause a boost in the labor market that offsets whatever incentive people may have to work less. We found those things kind of cancel out to the best that we could try to uncover them in Alaska. The final thing I want to say about these types of policies is that during the pandemic, what we're also seeing is that the timeliness of these policies is another dimension that we need to maybe rethink. So the earned income tax credit is the biggest cash transfer that we give out to low-income households, and it comes once a year, generally when you're filing your taxes. And so this year we had a pandemic and we had the need to give people cash very quickly, and the IRS kind of can do that through the tax system, but you know, it took a lot of work to try to track people down, to figure out what their current status is. And for some people who didn't sign up or who don't sign up in time, they'll have to wait until next tax season to get an economic impact payment for this year's pandemic. So this annual model of paying out cash transfers may need to be redesigned to think about a more frequent way to get people money in a more timely manner, closer to when they are in need and when they have an acute need for relief.
So I want to leave some time for audience Q&A, and if you type in your questions, I will do my best to read them and aggregate and pose them to our panelists. So get your questions ready and start typing them into the Q&A function. But before I do that, let me ask one more question. David, you mentioned working with students, having them incorporated into some of your research projects. Can you tell us a little more about opportunities for students to get involved in your ongoing research, or how you've worked with students in the past?
Yeah, I've worked with students for years, most recently through the policy labs. We've actually run a policy lab around the comprehensive care program for about 3 or 4 years. We did it once a year. We're actually doing it at this point every quarter. And in fact, one of the the person I work with most closely in developing the program is a Harris School graduate, and Emily Paris. So she's wonderful and has really helped us advance this. But most recently, we had a group of Harris School students out in the Harvey community in the Chicago South suburbs, working with Ingalls Hospital, which is a community hospital with which the U of C is affiliated, to work with them to do community development work, thinking about how to help that community, which has been in decline over many decades, figure out how to stabilize itself. And we were actually gearing up this summer to do a systematic social survey of the neighborhood, and that got delayed because of all the pandemic, but it's something that we'll get back to. One of the projects that I think I'm gonna have Harris School students work with me on in the coming months is an interesting sideline in COVID, which is I've become obsessed with the role of vitamin D in preventing COVID. And we're actually, we did an observational study, which I think is very close to publication, showing that patients who were vitamin D deficient and not treated were much more likely to get COVID than patients who weren't. And for those of you who don't know, the African-American community, Hispanics, are much higher rates of vitamin D deficiency than Caucasian Americans. And particularly, unfortunately, people who live in cold winter climates, which, Kate, I'm sorry to say, is the reality of Chicago. So we found these observational studies, and we're now gearing up to do a whole bunch of randomized trials. And the recruitment of that will be heavily community-based. One of the fascinating things about doing randomized trials of vitamin D is it's not a prescription medicine. So dispensing it is very easy. It costs about $5 or $6 per person per year to give this to people. And the biggest cost of getting it to them is actually the shipping. So by partnering with communities, we can literally get the product out there and have a distribution system set up that costs almost nothing. So we are trying to think through things like, how do we do 10,000 person randomized trials in a matter of a couple of weeks to launch them? And so those are some of the interesting things that we get students involved in. Fascinating opportunities to analyze policy issues related to this, and then also actually implement things in the community. I'll just share one last policy issue around vitamin D. I think it's a fascinating story. One of the things I discovered in the process of looking at vitamin D is vitamin D testing is not covered by Medicare. They don't consider it in general a valuable service. But interestingly, one of the indications for which they will cover it is if you have a previous vitamin D level that is abnormal. So wealthy people can afford to get their vitamin D levels test, identify that they're abnormal, and then get Medicare to pay for them for free. Meanwhile, the elderly African-American population, which probably has an 80 or 90% prevalence rate of vitamin D deficiency, can't get those things paid for because they don't have a level. And so it's a reminder that public policies, if they don't look through the lens of economics, at the same time they look at through the lens of health, really can be misguided.
So that last set of comments actually raised a lot of the issues that I'm seeing in the Q&A, and I'm going to aggregate a few questions together. To first ask, You mentioned, David, about telemedicine and differences in access to telemedicine based on digital literacy and access to Wi-Fi and the like. Also, some of the financial solutions, Damon, you talked about the problem with once a year big checks, and there's differences in access to bank accounts and other financial tech kind of solutions to smoothing income. So maybe I'll turn to Damon to say, what does the divide look like in access to some of the broader sets of solutions? And are there any policies that you think would make some of both the financial and health solutions more widely accessible to underserved communities?
Well, I think that some of our systems right now that we can use because they're the best that we have available to give out relief. So for example, unemployment insurance, we can invest a lot more in the infrastructure there. And I think, you know, there's an argument to be made that more federal guidance or oversight on how unemployment insurance is run could help to have more equitable outcomes across different types of people. There are differences across states in how generous unemployment insurance is, and that is going to cause a lot of variation in how much support people get. There are differences in how equipped the unemployment insurance agencies are in terms of rolling out these new changes that we've made. In fact, the reason why there is this increase of $600 per week in the unemployment insurance program is in part because the software they use is so old that this was the best thing that they could come up with in terms of tailoring an increase. It turned out to make it very generous, which may have been lucky if depending on how you view these things. But you know, some of this has to do with the infrastructure we have in place for these social safety net programs and these social insurance programs. Some of it is intentionally designed to be not as up to date, and so in some states where they have unemployment insurance but they want to lower the spending, they do it indirectly by not investing in the infrastructure. So I think that that's like a very boring type of solution, but you know, we sometimes underinvest there in terms of the infrastructure that's available to these agencies. And so I think that's one thing to think about.
Let me just add that I think one of the huge things in these challenges is the ability of people to access these benefits even when they are technically available to them. These complex bureaucracies absolutely overwhelm the most vulnerable individuals. They don't get access. It's often the most well-off people who are beneath the threshold who benefit from these programs. One of the areas where we've put a lot of effort in is by mobilizing some of our students and some of our AmeriCorps members to try to actually help patients access benefits that they really could be benefiting but aren't. One example of that is literally making them available to help them figure out how to use their smartphones so that they can access things. And once you show them, very often they can do it. There's some who can't anyway, but there are many who can and just need that help.
So David, your discussion of the vitamin D work highlighted an issue that's near and dear to my heart that also has shown up in our Q&A panel, which is the way that we pay for healthcare and how that influences what's available, the efficiency of delivery, who has access to what services. We're living in a world where Medicare patients, a lot of them are in fee-for-service, and other insurance is experimenting with more value-based payments, but it's a very patchwork system. And what payment reforms do you think would best help us not only expand access to care, but also focus our resources on the care that is improving health the most?
Yeah, so, you know, there's a long history of economists' skepticism about the fee-for-service healthcare system in many ways. And, you know, going back to even Milton Friedman, views towards other systems that are capitated and create these incentives to avoid overutilization, and some would argue to improve health. I have to say, I am increasingly skeptical of those models. when I see them in practice, particularly for the most vulnerable people. What I see are systems that are so badly risk adjusted that the patients who most need our help are the ones these entities least want to care for. And because of that, the patients for whom we could really make a difference are the patients who are actually left behind with these systems. So I think there's a need for some sort of Manhattan Project to figure out how to do risk adjustment well, particularly for these most vulnerable patients, and address it. The other thing I would say is that the system that we have in which we essentially underpay privately insured patients and make up the difference by subsidies for we underpay publicly insured people and we overpay privately insured people, creates these incredibly horrible incentives for overutilization in the private sector. And what we would probably be far better off if we did is really be honest with ourselves about what it costs to care for poor people, pay rates for that are reasonable, much closer to Medicare, and eliminate then and only then the tax deductibility of employer contributions for health insurance and really drive down those private premiums. That, I think, would be a much more logical model. The trick in doing it is that you can't get rid of the tax deductions and then hope that the rest is going to work out, because you'll destroy institutions in the process of doing that. But if you could start, and Illinois is sadly among the worst states in the nation with respect to Medicaid rates. If you could start by fixing Medicaid and improving access, then I think you could start to improve the efficiency issues.
Now, a common thread for improving access through Medicaid, expanding the earned income tax credit, social safety net programs, is that a lot of these are publicly financed programs, whether it's today's tax dollars or deficits that roll over into tomorrow's tax dollars. And there's some great questions in the Q&A about the financial sustainability of this for federal government, states, and localities, and what the implications are for the political viability of all of these solutions that rely on raising more money in taxes. How do we think about the fiscal constraints? Damon, you work in public finance. David, you're an economist as well as a doctor. How are we supposed to pay for all of this?
Yeah, I think one thing to separate are the short-term measures that we're talking about to address the pandemic, and then longer, more permanent changes to the levels of government spending. The easier one to address is the short-term thing where, I think that we need to err on the side of spending more than being too worried about the deficit in the year 2020. We have this crisis that we're facing. We need to, this is the exact time where the federal government is in place, especially in the US, to go into a little debt to try to get us out of this problem. And so I'm not really worried about deficits right now, given the benefits that come from where we can spend money right now to help to try to stem an even longer recession and loss of hundreds of thousands of lives. So the budget questions right now, I think, are very easy to answer. We should throw money at this problem, and the federal government in particular is in a much better place to bail out people than local state governments who have just tighter budget constraints and have a harder time borrowing and going into debt because they have these sort of balanced budget requirements. So the federal government can step in and also can give aid to a lot of local state and local governments. We're seeing higher employment growing in the public sector, where local governments are starting to have to fire people and send people into unemployment. And the federal government is the one who's in place to spend the money now and pay it off in the long run. So I think that's one question, and the other is about the size of our social safety net in general, and how we can pay for these things. And the only thing I would say is that I don't think that there is just some hard and fast fundamental limit on the type of safety net or welfare state we can have. I mean, there's just a choice about how we want to think about inequality, and you know, a decision. There may be some trade-offs there, but in terms of what's possible, in terms of the menu that's available, there are a lot of developed countries that have a wide array of levels of social safety nets that they're able to achieve. And so I don't think the financing of these things is the key limitation, because we can see that things are possible in other countries who are peer to us. So I think that what actually we have to think about is there the will to do this? And in particular in the United States, if you look at historically, race has played a major role in framing these debates, either explicitly or sometimes implicitly, when we're thinking about things like welfare and other public goods and publicly provided benefits. And so I think that people who want to achieve a lower levels of public spending can do that more easily if they can racialize these public benefit programs and help to divide people in terms of whether they support them or not based on things like racial identity, as opposed to thinking about what could be beneficial to those who are at least the less fortunate in our country. So I think that's an additional barrier that we face, particularly in the United States, given the long history we have with race.
Thinking about the financing of healthcare, one thing I'll just point out is that we are on the cusp of this incredible expansion of demand for healthcare related to the aging of the baby boomers. So I think it's a perfect time in many ways to actually cut back payment rates for the private side of healthcare and let the healthcare system make it up in volume. And I think that could be one of the big places where a fair amount of money sits in our society that could help us deal with this. But I think Damon's exactly right. This is not a time to balance the budget. It's a time to invest in meeting these basic social needs. And I think anyone who doesn't, you know, anyone who looks at what's happening in the States where the incidence of COVID is you know, rising so rapidly sees the costs for the economy of failing to address these basic public health needs.
Well, that seems like an appropriate note from both of you to end on, and obviously not the end of a really important set of conversations, but the end of our hour right now to discuss them. I'm so grateful to Ben for the introduction, and to David Meltzer and Damon Jones for sharing their time and their wisdom on these crucial issues. And I hope that it's been engaging for those of you in the audience, despite the sort of one-way nature of these kinds of webinars, and also highlights the importance of the work that our faculty and students together are doing to address the pressing issues of the day, and the opportunities for you to get involved and engaged. And I think there are going to be a lot of opportunities in the coming year, remotely or in person, to work with faculty members like Dr. Meltzer and Dr. Jones to think about how we can improve public policy, because it's clear from this conversation and so much more that these issues are going to determine the well-being of so many people in the population, and especially those most vulnerable. So thank you for your work, and thank you for your time, and thank you for sharing the time with us, those of you in the audience. And I look forward to virtually seeing you again at another Harris event very soon. Thanks all.
Great, thank you.
Thank you.